Hey, it's Benji Cole, son of Al Cole from CBS Radio and host of the syndicated talk show, People of Distinction. The talk that gives you an in-depth view of some of the most dynamic, intelligent, and successful people on the planet. Run to our website, alcoleenterprises.com, for more info. Email me through benji@alcoleenterprises.com if you'd like to get involved with what we have going. And as always, please continue to like and follow our broadcasts. People of Distinction is internationally syndicated solely due to the love and support that you all continue to give. We're available across all major distributors, and as long as you keep following, we're going to continue to put out the content. Now sit back and strap in, because on the line with us today, we have the impressive Jordan S. Fersel. And we're going to be discussing his incredible book, When Bad Backs Happen to Good People. It's not all in your head. It's Amazon, it's Barnes & Noble, it is a lot of other places. But if you want to gather everything that Dr. Fersel has in store, man, you got to check out his personal site, okay? And that's drjordanferselauthor.com. There, gather more information on him, on his book, hyperlinks set up to take you to the purchasing pages. I'm telling you, it's a one-stop shop. Once again, that's drjordanferselauthor.com. And I quickly want to point out the fact that Jordan was brought to us by Studio of Books. So for my writers out there listening in, if you've gone through your process, you've had some sleepless nights, and now you find yourself in a precarious position, man, because now you need some assistance moving the book you just developed. Well, head on over to studioofbooks.org and gather all of the ways that their fantastic team is going to help you do just that. And listen, it is an absolute pleasure to have Dr. Fersel here on the line. People, right there in the title, you got an idea of the discussion at hand, and I promise you it's much more than just a catchy title, okay? He is going to be bringing in knowledge from his experience, from his career, and something that I know we all need. Yeah, me personally, listen, I'm just going to tell you, when it comes to my back pain, I remember probably dating back to when I was a teenager, all those years ago. I was very much into sports. It literally was every single day from 2 p.m. to about 9:30 at night. I was at the basketball courts and I was playing. It was one of the things, A, I love to do, but B, it kept me on the straight and narrow, right? It was something to keep my focus on and keep me away from other distractions. But because of that, and years, now, decades later, man, my back is, I can tell sometimes, like I don't get to play basketball as much as I used to. And even when I do, I come home, I'm going to need a couple of days of rest. And we've all been there, right? Where we're dealing with that chronic back pain. And we've heard it, right? Sometimes we hear it's just a slipped disc. Others, we hear it's all in your head, like his subtitle. Sometimes the real answer isn't found on an MRI, but in a revolutionary understanding of your nervous system itself. Now, listen, today we are sitting down with Dr. Jordan Fersel, who is the author of this crucial book, and he is going to debunk the myths, expose why standard approaches often fail, and reveal the empowering science that can help you take your life back and get ready to rethink the pain. I'm telling you, this is going to be a fantastic education. Sit back and strap in. Here we go. Jordan, first and foremost, welcome to People of Distinction, man, and thank you for being a guest. How are you doing today, sir?
Great. Thanks for the introduction.
Absolutely. It was my pleasure. Jordan, listen, man, we're looking forward to the wisdom that you're going to be able to share with us. And I know that we're only going to scratch the surface during the discussion, but it's definitely going to give us a wonderful introduction to what to expect. Before we go into your book, Jordan, start off by telling us a little bit more about yourself and your background, please.
Okay. I'm a native New Yorker. These days I'm living in New Jersey, not so far. And I went to Mount Sinai School of Medicine. I did a residency in anesthesiology. And I had always been interested in the topic of chronic pain. And actually that was really, at that time, there were only two ways to get into the field of chronic pain, either through physiatry, which is physical medicine and rehab, or anesthesiology. So I opted to take the anesthesiology route. And that was more a learning by doing process in terms of giving injections and those type of things, not as much of a musculoskeletal approach as a treating the injury part. I did a year of fellowship in Newark for pain management. It was very early as pain management was being just first recognized as a specialty in medicine. And the only thing I can tell you is we've come a long way since then in terms of what we can do for our patients, but we're not completely there.
Okay. Listen, jumping right into the book now, Jordan, I love what you've done with the title, right? Because it's such a great approach to all of this, because the title is a declaration, right? Like, it's not all in your head is a powerful rebuttal to a phrase that so many people have heard, right? Myself included. I'm wondering, going back to the start of this, leading into the inspiration, was there a specific patient, story, or a moment in your career that cemented the need to make this declaration as the central thesis of your book?
It's funny you should ask that. I have to tell you, I did a year fellowship in pain management, and there were two co-directors of the clinic. One was an anesthesiologist and one was a psychologist. And every Friday we would have our rounds in which we would go over the patients. And I have to tell you, I would say just about every time we got together, I was looking for medical reasons that the patient might be experiencing pain, and the psychologist was looking for psychological reasons. And I just turned to him once. I said, I guess it could be both. Which of them is the dominant one? And he was sure that it was the patient's brain, the thought processes and the emotions that they had. And I was certain that we're just missing something here. And in those days, this was about 1987, 88, we weren't so sophisticated in terms of our ability to diagnose and treat a lot of these patients. And still today, we're not sophisticated enough. And so there was this constant tension in all of our meetings. And it unfortunately didn't work out well for me because they had offered me a job and then they withdrew it.
Oh, no.
Because of all the fighting.
Oh, no.
It's okay. It all worked out. And anyway, the important thing is really to stick to what you believe in. And that's what I've done my whole career. I try to believe in the patients. There are some of them that maybe there are questionable issues with regard to them. But I have to tell you, the average person that on Tuesday had a really nice life, a nice family, a nice job, and was involved in a serious car accident, and on Wednesday they're just totally debilitated. My tendency is to give them the benefit of the doubt until I think that I'm being betrayed in some way. And most people are pretty honest. They just want to get back to their function and their abilities from before the trauma that they experienced or before the medical experience, the medical disease that they experienced. People don't just go to the doctor because they want to get drugs. Some people do, but it's a minority. And you really have to give the patient the benefit of the doubt. And by doing that, it enabled me to start looking at these patients in a very different way. And I wasn't so much at odds with my patients anymore that they're trying to get something from me, but rather it was like, what kind of things can I do, or what kind of thought process would be helpful for me in order to help you get better? And so it was always there. That was like the nucleus. That was the feeling that I had from the beginning. But I have to tell you, it's a crazy position to be in because let's face it, people that go to medical school, they're used to having done well in high school and in college on exams. And here you have these patients that are coming to you and they have really serious problems that affect every aspect of their lives. And you try to help them out and you're maybe 25, 35% successful with them. So it's ego crushing at times. It's not all about me, but certainly I went into medicine to try and help people. And certainly we'd like to be more helpful than 35% success.
Listen, Jordan, You're touching on something that I think is very compelling because you're talking about chronic pain. And of course, we are addressing the physical ailment of the pain itself, but we're also wanting to acknowledge the duality of the psychological pain that coexists, right? And we can't negate that. That's part of the process. And it brings up an interesting connection, right, to my next question, because you mentioned before, a lot of patients, they just want to get back to who they were before this particular incident, before the particular injury that occurred, right? Like the runner who can't run anymore, or the parent who no longer can lift their child because of the back pain and so on and so forth. How does your treatment philosophy address this profound emotional and psychological component, not just the physical symptoms themselves?
So we have to figure out a way to look at our patients. You're right. They're not like a body that's just experiencing pain. No, they're a person. And the person has, some of these people, they have psychological issues even from before, the pain began. Yeah. I mean, they have emotional issues, and there are cultural issues, and there are gender issues. And all these things play into a person's ability to deal with and cope with the pain. But the question that I always asked myself was, what has primacy? Which of these issues is the one that is going to help the patient the most if I deal with their emotional, psychological, mind kind of problem first? And there are many doctors who do. There are many clinics that have extensive psychological treatment and behavioral modification and all kinds of biofeedback. And there was a doctor, you may have heard, his name was Don Sarno, who wrote a book called Mind Over Back Pain. And I allude to it in the book. And there are some people that they will tell me, they will tell me, I used Sarno's method, and I was able to throw away the walker. I was able to throw away the cane. And there are people, for sure, that have some emotional overlay, some stress response that causes the muscles to go into spasm. As I said, we're dynamic beings. We have both the mind and the body. Mm-hmm. But that wasn't what I was searching for in the name of my patients. What I was searching for was the physical reasons that they might be experiencing the pain, and that it would sometimes manifest in emotional issues, in relationship issues, in drug-seeking behavior, all those kind of things that these are societal problems. These are not just my patient problems. If you take it and you amplify it by the, say, 100 million people at any time in this country that may be experiencing chronic pain, then, you really have, you have to have a perspective. You have to have a philosophy of looking at these people. And I always said to my patients, especially in the early days, but even now, I would try and reassure them. And I would say to them, look, if you had a normal life before X, Y, and Z happened to you, and then this happened to you, and you have all these terrible things that are going on, this experience that you have, this suffering that you have, I'm going to look at it as though there's something physical going on that's just affecting you in your emotional, psychological, spiritual world. And we're going to look for that first, because if we can find that, then I can reverse a lot of the issues, a lot of the mind issues that you're experiencing. And by the way, it's not just mind issues, it's brain issues. In other words, there was a study done a number of years ago that, there was a patch that we use. It's called lidoderm patch. And so a patient had an injury to his arm, had some scar tissue that was involving a nerve, and they did special MRI scans of the brain, and it showed that the brain lit up in certain areas. Then they took one of these lidocaine patches, which are called lidoderm, and they put it on the arm in the area where the injury was, where the pain was emanating from. And they found that the MRI scan of the brain went back to normal. When I saw that, I just said, wow, that I could do something for your arm, and it's going to affect so profoundly your brain. So imagine what we could do if we could figure out what kind of things are going on with these patients, if they are indeed physical problems or if they're more psychological problems. But if we got a good beat on it, on the physical part, boy, that would be a game changer for a lot of these patients. Mm-hmm. And let me tell you something. Why I wrote the book is because I've seen it over and over again. We just are in our infancy in terms of being able to describe the effect that certain injuries have on the nervous system of the patient, on their brains, and on their psychological and emotional functioning. So I'm like a crusader. I'm trying to pound down the point that keep looking for the physical, because if we can identify something like that, then it's going to have a strong impact on the emotional.
Right. I love what you're talking about here, man. Remarkably compelling. And people, trust me when I tell you, the book is filled with so much education. We aren't even going to scratch the surface here today. You know what you got to do, man. You got to purchase your copies. There's really no other way around it. My last couple of questions here for you, Dr. Fersel. You mention in the book the helping readers go against that unnecessary surgery. And again, married to a physician, man, I see the darker sides of the medical field, and I'm not casting any aspersions. I'm not pointing any fingers, but there's a lot of reasons why certain things are pushed on certain patients. And it's not always just solely to treat a particular ailment. That's all I'm going to say on it. But my follow-up now, what are some of the key questions, man? If there's a patient listening in right now and they're getting ready to go talk to their surgeon, before they consent to a procedure to ensure that that procedure is actually necessary and not just the next step option, where should they even begin? What questions should they be asking?
Yeah. So, Benji, I don't want to give medical advice,
of course, absolutely,
to any particular kind of person. But let me go from 30,000 feet, okay, and just describe the problem for you a little bit so that people will have a way of looking at things that might be different than what they're used to. So way around 1990, there were papers that were coming out, and the information that was coming out in them was basically just epidemiological studies of people in society. And one of the papers that came out, in Spine, one of the medical journals, stated that about 40% of people who have herniated discs or bulging discs are walking around with absolutely no pain. So that's a dilemma.
Wow.
That's crazy, right? Because what it tells me is that, hey, just the fact that you have a herniated disc or a bulging disc, it doesn't mean that's what's generating the pain. Mm-hmm. And another study came to my attention recently, and that had to do with knee arthroscopy. We're dealing with the whole body. It's not just a back. I wrote it about backs, but that the principles in this book can spread to almost all areas of the body. So in terms of the knee pain, they looked at males over 50 that didn't have arthritis, and they found that 63% of men who had knee pain had a meniscal tear. That's a tear in the cartilage in the knee. And I'm sure you're an athlete, so you're well versed in that. And the cartilage is really an area where it's heavily invested with nerves. So you'll feel the pain. It's like a hangnail inside of your knee. Every time you move, you feel it. And then they compared it to men over 50 who had no knee pain, and they found that 61% of them had meniscal tears. So that's crazy, okay? So how do I know who to operate on, okay? If you do have pain, you have a meniscal tear 60% of the time. If you don't have pain, you have a meniscal tear 60%. So seems to me like that's part of the human condition as you age, that you might have a tear in the cartilage of your knee. So how do I know who's going to get better if I operate on them and who's not going to get better? So that was really the thought process that is the engine behind this book. Okay, what is it? What is the thing that these things have in common that it causes the generation of pain? And in fact, what's the future of pain medicine? It's called targeted therapy. I think I mentioned it a few times in the book. And what we're looking for is areas in the body that are responsible for the physical pain that you're experiencing. And if I can identify those areas, then I can actually treat them. But I have to have a good understanding of the nervous system and the anatomy and the physiology. And even, believe it or not, I got a lot of my concepts from biomechanics, just trying to understand the physics of injuries. I was dealing with patients in car accidents for many years, and gave probably between 8 and 10,000 second opinions of comments on what other doctors had done. And that's why I felt really qualified to write this book, because I have now such a body of knowledge that I'm able to see like the gamut, not just of the way that patients present, but of the way that doctors would diagnose them. And some did a better job and some didn't do such a great job. But it was such an educational process for me that by looking at all this data, it's almost pre-AI. I had all these data points, but very crude, but I had all these data points, and I am saying to myself, what makes them connect? What kind of things have other things in common with them? And it just hit upon me that some of this stuff has a tremendous connection to abnormalities or inflammation in the nervous system. And not, when I'm saying the nervous system, I'm not just talking about the spine and the brain. I'm talking about the nerves that course through your body, what we call the peripheral nerves. They get injured. They themselves get injured. And these types of things, they're not taught well in medical school. They're not taught well in residency. They're not taught well in, at least until now that I'm aware, in pain management fellowships. And I was so lucky that as part of my training as an anesthesiologist, that we learned how to anesthetize certain parts of the body just with injections, with local anesthetics. Like you can do a hernia operation just with local anesthesia. You can do certain ankle or hand surgeries just with local anesthetic blocks. And these formed the basis for the understanding, the ability to find those nerves that once they're anesthetized, create a situation where you can do surgery. Those same nerves, if they become injured in a accident, like a car accident, a work-related accident, a fall, a slip and fall, all those kind of things, they become activated and they become chronically inflamed. And that became, and there's literature to support that in like mice and rats, many years old. And that became the basis for my understanding of what's going on. Now, I just have to give one caveat, because I don't want anybody to think that I have all the answers for everybody. It's not true. Okay?
Yeah.
There's still a lot more that we need to learn. There are new tools being developed. I can go into it in some other time, but the next 10 years in this field of pain management are going to be explosive. Okay, we are going to be able to find things with people that are wrong with them that we never would have imagined. Great precision and accuracy and the ability to treat them such that nobody is going to have to live, or almost nobody is going to have to live with terrible pain for years and years like they have up until now. And I've always said to my patients, I know you're still having pain, and I just want you to know that I believe you, and I just want you to hang in there until we get the science, until we get more information. And we are truly on the precipice of that, and that's why I wrote this book.
Dr. Fersel, listen, man, I understand that you wanted to point it out, and I think it's an important disclaimer to put out there, because we, of course, don't want to make blanket statements. And yes, you don't have all the answers. The book doesn't, but if there's one thing that I'm taking from today's conversation, and I know my listening audience is as well, is your pain isn't a life sentence, right? Your diagnosis is not your identity. There are ways to go about this. There is a process. And your book is magnificent because it really starts our listening audience and starts your readers on that journey toward a different tomorrow. And it showcases that, listen, the process, it doesn't end with this conversation or with your book. It literally starts there. So people, I'm going to tell you again, it's Amazon, it's Barnes & Noble, drjordanferselauthor.com. Head on over there, pick up your copies today. Once again, it's entitled, When Bad Backs Happen to Good People, It's Not All in Your Head. And this is a game changer, man. It's going to start you on that journey and really help you get a clearer picture of the journey ahead towards that recovery. And it's so important to that process. Head on over there, pick up your copies today. Dr. Fersel, this has been just an enlightening conversation, man, and I truly appreciate it. Thank you once again for being a guest on People of Distinction.
This was a wonderful experience. I really appreciate you. You're going to make me want to write another book.